All right, let's jump right in. Welcome back to another explainer. Today, we're taking aim at an absolute heavyweight on board exams, Toxoplasma gondii. Now, we're not just going to read you a list of textbook facts. No way. We're actively hunting for the specific exam traps, the diagnostic paradoxes, and the absolute do-not-miss management rules that examiners practically live to trick you with. So grab your notes, get dialed in, and let's decode the high-yield blueprint of Toxo.
Here's our rapid-fire agenda for today. We've got 1. Life cycle traps, 2. The gestational paradox, 3. Clinical syndromes, 4. Serology traps, and finally, 5. Management rules.
Kicking things off with Section 1, Transmission and Life Cycle. Okay, so the parasite's life stage completely dictates how your patient actually gets infected. Think of it kind of like a shapeshifter. First, you have tachyzoites. These are the rapidly dividing guys responsible for acute disease, and they just disseminate everywhere. Then you've got bridyzoites. These are the slow dividers hiding out in chronic tissue cysts, specifically in skeletal muscle and the central nervous system. And finally, sporozoites, which are found in sporulated oocysts. Now, here is the massive exam trap. Everyone knows cats are the definitive host, excreting millions of oocysts in their feces, right? Well, actually, while that's true, do not ignore the intermediate hosts. Ingestion of those bradyzoite tissue cysts in undercooked meat, we're talking lamb, beef, or pork, is a hugely tested secondary route of transmission. Keep your eyes peeled for that classic vignette patient who just ate undercooked venison. Moving right along to Section 2, the gestational paradox. Now, before we hit the actual paradox, you absolutely need to know the golden rule of maternal protection. If a woman is seropositive, meaning she had her primary infection more than 6 months before conception, her fetus is completely protected. The risk of transmission there is essentially zero. The real danger zone? That's primary infection during pregnancy or right before it. And here is the mind bender they love to test. In the first trimester, the actual rate of fetal transmission is surprisingly low, hovering around 15%. But if it does cross the placenta that early, the fetal disease is at its absolute most severe. We're talking ruined organogenesis, intrauterine death, or the full classic triad. Now, fast forward to the third trimester, and that transmission rate skyrockets to roughly 65%. But here's the paradox. The disease severity drops dramatically. These infants are usually completely asymptomatic at birth, though they can, develop neurological issues years later. So, low transmission but high severity early on, high transmission but low severity late. Lock that in. Knowing exactly what that severe early disease looks like is a guaranteed point scorer. If you're reading a pediatric board question describing a neonate, you have to aggressively scan for this classic congenital triad: chorioretinitis, intracranial calcifications, and specifically periventricular calcifications. Don't mix that up with CMV, which is often periventricular too, so look for the other clues. And finally, hydrocephalus. You see this triad? The test is practically screaming toxoplasmosis at you. All right, let's pivot to Section 3, Clinical Syndromes by Host. Toxo is a classic opportunist. How it shows up depends entirely on the immune status of the patient in front of you. For your average immunocompetent adult or child, 80 to 90% are going to be completely asymptomatic. But if they do show symptoms, what's the number one presenting sign? Cervical lymphadenopathy. The nodes are discrete, they're non-tender, they might even have a mono-like syndrome with fever and malaise. But here is your differential key: their heterophile antibody test. It will be negative. Definitely file this one away. Toxo is literally the most common cause of posterior uveitis in immunocompetent individuals worldwide. If you get a fundoscopic exam in the prompt, look for yellow-white cotton-like patches with indistinct margins, usually hanging out near the posterior pole of the retina. The patient is going to be complaining of blurred vision, scotoma, and eye pain. Okay, 100. That is the magic number. This is the absolutely crucial CD4 threshold you need to memorize for AIDS patients. When that CD4 count dips below 100 cells per microliter, those latent bradyzoite cysts we talked about, they reactivate. And this leads straight to cerebral toxoplasmosis, making it the most common CNS mass lesion in AIDS patients. And because it's the most common mass lesion, examiners are obsessed with making you differentiate it from the second most common, CNS lymphoma. Toxoplasmosis classically lights up on a CT or MRI as multiple ring-enhancing lesions, specifically at the basal ganglia and the corticomedullary junction. CNS lymphoma? That's much more likely to show up as a single lesion. So, rule of thumb, if the vignette describes a single CNS lesion in an AIDS patient, lean heavily toward lymphoma. If it's multiple ring-enhancing lesions at the basal ganglia, you are dealing with toxo, which leads us perfectly into a classic next step question. Put yourself in the vignette. You have an AIDS patient. They've got multiple ring-enhancing lesions. You start a therapeutic trial of empiric toxotherapy. Normally, you'd see improvement by day 3, and over 90% get better by day 7. But what if there's absolutely no improvement by day 7? What is your immediate next step?
Boom, brain biopsy. Do not tweak the antibiotics. Do not just sit back and observe. You need a tissue diagnosis right now because your empiric trial failed and you might actually be staring down that CNS lymphoma we just talked about.
Let's move to Section 4, Serology and Diagnostic Traps. First up, just know the name of the gold standard test, the Sabin-Feldman dye test. It's an IgG assay. Basically, live parasites are stained by a dye in the presence of the patient's antibody and complement. And remember, IgG antibodies persist for life, which is exactly why this test works for figuring out if a patient has ever been exposed. Next, we have antibody avidity testing. This is the exact tool you want for assessing risk in those pregnant patients we discussed earlier. High avidity means the infection happened a while ago, more than 3 to 4 months ago, which means the fetus is likely safe. Low avidity? That means you're dealing with a recent acute infection, and that fetus is at high risk. Okay, listen closely, because this is arguably the biggest diagnostic trap on the boards. Usually, IgM antibodies mean acute infection, right? Well, not necessarily with Toxo. IgM can literally hang around for more than a year after the initial infection. So, a single isolated positive IgM alone does not confirm an acute infection. You absolutely have to have both IgM and IgG heavily weighed with the clinical context to confirm an acute diagnosis. Do not fall for the solo IgM trap. And finally, we arrive at Section 5, High-Yield Management Strategies. This one trips up so many people. It's a massive pharmacological trap. The standard treatment for acute cerebral toxoplasmosis is pyrimethamine plus sulfadiazine. But you must co-administer leucovorin, which is folinic acid, to prevent severe bone marrow toxicity from the pyrimethamine. The trick? The test makers love to slide folic acid into the answer choices. Folic acid is wrong. Folic acid actually interferes with the pyrimethamine. You need folinic acid, leucovorin. Remember that distinction. Now, what about managing pregnancy? If a woman is in early pregnancy, meaning less than 18 weeks, you go with spiromycin. It's a macrolide that does a terrible job crossing the placenta, so it concentrates right there and blocks transmission to the fetus. What you absolutely, under no circumstances, can use in the first trimester is pyrimethamine because it is highly teratogenic. You only switch over to pyrimethamine, sulfadiazine, and folinic acid after 18 weeks of gestation, or if you have rock-solid documentation via amniotic fluid PCR that the fetus is already infected. Let's rapid-fire the AIDS prophylaxis rules to close this out. If your patient's CD4 count drops below 100, you start primary prophylaxis with TMP-SMX. The really elegant part about this? That one pill covers them for both toxoplasmosis and PCP pneumonia at the same time. And when can you safely stop it? Once they're on ART, you stop primary prophylaxis when their CD4 count climbs above 200 for at least 3 solid months. Now, if they actually had a toxo infection and are on secondary maintenance therapy, you have to wait until the CD4 is above 200 for at least 6 months before you can pull the plug on the meds. Well, we've covered a ton of ground today, from shape-shifting tachyzoids and that wild gestational paradox to differentiating brain lesions and nailing down some very specific pharmacology rules. Toxoplasma is just one of those topics absolutely packed with exceptions and paradoxes specifically designed to test your attention to detail. So, knowing the traps, are you ready to dodge them on test day, review the high-yield facts, lock down those CD4 counts, and go crush those practice questions? Thanks for hanging out with me on this explainer, and I will catch you on the next one.